morning, ladies and gentlemen. Welcome to this episode of Aspire Ed Talks. I'm Dr. Durusha, the Vice President of Aspire and Chair of the Education Committee, Director of Gynec World in Mumbai, India. I would like to introduce our guest for today, a dear friend, Dr. Sonia Malik, who is currently the Chief Clinical Mentor of Nova IVF in India. And she's also been the past president of the Indian Fertility Society. So welcome, Sonia, to this TED Talk, which is a talk meant for many clinicians who are interested in this area. It's going to be very focused on, does luteal support differ in frozen ART cycles? This is something, yes, this is something which we are going to focus on, and we are going to talk only about it and really get into the depth of the subject. So let me start with telling you what exactly, or asking you, what exactly are the strategies to improve ART outcomes? We all know that there are various strategies, and the most common is the luteal support. Most important, I think, when we are putting in the embryo. We have strategies like improving the stimulation, improving the endometrial embryo asynchrony, getting it better, taking care of the endometrium, etc. But when it comes to luteal support, there are various issues which are related to it. So let me first of all ask you that what really is the difference between a fresh cycle and a frozen cycle, and whether it matters what luteal support you use in either of these cycles.
Thank you, Duru, for starting it really on the right note. That is the first part of the controversy that we are going to talk about today. And we all know that we've been struggling a lot to actually conquer the, I would use the word conquer, the luteal phase of the menstrual cycle, because basically the uterus is a black box, as they say, and we really do not know what is happening there once we put back the embryo. So you see what has happened when you ask me what is the optimization of the luteal phase that we are talking about. It has taken us a lot of time to really understand that we have to focus on this part of the menstrual cycle as well in order to better our results. And so when you talk of the various strategies that we are going to use or we are using, it is essentially to synchronize the embryo with the endometrium in order to make it implant. And when you said, what is the difference between a fresh and a frozen cycle? That exactly is what is happening over there. We are generally transferring a day 5 embryo, and we do not know whether the endometrium is at that stage or not, because we have developed too many follicles over there, and therefore there is asynchrony between the endometrium and the embryo that we are putting in. So in a fresh cycle, it tends to sort of cause a little bit of a disharmony between the crosstalk, and hence you don't get such good pregnancy rates as you do in a frozen cycle, where you're very particular and very careful in developing the endometrium the way it should be on day 5 when you're transferring a blastocyst inside. So that is how we look at it now, and I think as we go ahead, we will be able to know a little bit more about it.
Absolutely. So question is that we know that there are many centers today who are doing a frozen cycle for every single patient, and they find it probably more convenient. Is it that the only reason, or the results are better with frozen cycles?
Well, I would say it's not the convenience. It started because, we found that, well, I would go back to saying that the hyper responders were the ones that taught us, because basically we were scared of OHSS and we started freezing them, completely. We had an all freeze kind of a clinic where you are freezing all the embryos. And of course, then what you said was convenience came in, and we find that frozen embryos are easily, we can sort of live a better life if we do it that way. But then having said that, the pregnancy rates definitely are better with frozen embryo transfers than fresh cycles. And that is why the world has now shifted on to frozen embryo transfers. Although in India, we still have centers where lots of people are doing fresh transfers, because basically the embryologists are not, we don't have that many embryologists yet in India who can cater to this kind of a service. And of course, there are people who are still doing batching in India, where again, this may not be possible. So all kinds of things, all kinds of factors attribute to this kind of cycle.
Yeah, absolutely. And I think almost 70% of cycles are being done as frozen cycles. And therefore, we need to understand how really we need to support the luteal phase through luteal support. We know there's enough evidence through RCTs that progesterone is the much needed hormone for the luteal phase. And there is enough evidence to show that it helps to improve pregnancy rates if your progesterone levels are good. And if that uterine contractions, which are reduced with the progesterone, give us better success rates. So if the question to you is that when we are using this progesterone, how do we know we are using the correct amount of progesterone?
That's a question which would fox anybody. It's $1 million question.
Thanks for you.
Then yes, we have to answer it, because my patient in front of me is also going to ask me the same question,
Yes.
And progesterone, I think, is the most misunderstood and late developed molecule, as I would say. We've known it for a long time, but we haven't paid enough attention to it. But now, of course, we are realizing that it is one of the most important parts of the menstrual cycle as well. And so measuring progesterone is not easy. If you there are 3 routes, as you know, of using progesterone. It could be oral, it could be vaginal, and it could be parenteral, intramuscular or subcutaneous. So basically, it's the best measured is the parenteral, which is intramuscular and which is going to show you blood levels. But when we talk of tissue levels, that then again, there's a little bit of a controversy over there, because you cannot measure the vaginal levels properly, and the oral medication that is available to us. We have 2 kinds of salts, as you know. It is either the natural micronized progesterone that we are using, and we are also using dihydrogesterone. So these molecules cannot be measured adequately in the serum. They do give us blood levels, but then, we cannot really say that they are the correct levels. But having said that, majority of the papers have zeroed down on 9 nanograms or 10 nanograms should be enough before we transfer a blastocyst. This is what most of the literature is saying. And hence, most of us are trying to achieve that level before we transfer. So there is a rough guide to it. I wouldn't say this is the exact thing, because you do find freak pregnancies happening even at 2.5, 3.5 progesterone, and higher levels of progesterone as well. But you can't say that. But optimally, yes, that is what it is.
Yeah. So question is that if before you transfer the embryo, do you do the levels before you transfer?
Well, I do. I always measure the progesterone on the 4th day. It's like I said, it's for my own satisfaction, I feel that, okay, at least we've made a good endometrium. And if we by chance have done a mock cycle before that, for instance, an ERA cycle, and you've measured the progesterone on day 4, before doing an ERA, then you are a little confident that, okay, that was what the level was in the last cycle, and this is what it is in this cycle. So we are fine. We won't be wrong. So it gives you a kind of a comfort. But I wouldn't say all pregnancies happen like this. They don't.
No, I agree with you, but it's agreed that when you have a failure of IVF at the end of the cycle, sometimes it's a documentation to know whether
Yes.
was progesterone low, was that the reason? And I think I agree with you. And there is also something called a rescue cycle. Say we
Yes.
find progesterone low, we may give a higher dose of progesterone and then do the transfer, or we may
Correct.
cancel the cycle completely, depending on what finds. Of course, what we are discussing today is something which is little out of the box. It's not the routine guidelines which we talk about, which I'm sure all our readers have done. All the guidelines are all there for everyone to read. These are small little practical, nuances or controversies which we are discussing today, and trying to find solutions for problems which we may have sometimes in our own practices. So question again to you is that,
let me just, so you see, again, when we were talking of this day 4 progesterone, again, there is a little bit of a catch over there, because basically when you have transferred the embryo, After that, there is a long luteal phase still left over there. And we do not know whether the progesterone falls or it remains the same. Can't keep on checking. And then what also happens is when you do find that it has dropped, then you do not know what to do because you've already increased or enhanced the progesterone on day 4 when it was low. And then again, if it is low on day 21, you're testing it again, it is low. It is telling me that the implantation is not going to happen. But what do I tell the patient? She gets so alarmed. So, too much of testing also, Duru, can upset the patient sitting in front of us because we don't have answers for what we are doing. We're just doing it. Like you said, these are the nuances that we are discussing, and we don't have answers for very many of them.
And that's why this episode is being recorded so that we can all learn from each other as to what is really helping. There is another question here, is that when you said that the progesterone is not, it's always remaining low and the implantation is not happening, could there be something like a progesterone resistance?
Thank you for that question. Actually, we in India have always been using a very high dose of progesterone, and I think the IVF specialists have been blamed also for using too much of progesterone in our patients. We give two forms. We give an oral and a vaginal, or an oral and a parenteral, and we have been criticized because the world everywhere is using one. But now gradually we are realizing that there is a subset of patients who do require more progesterone. And these are the ones who are showing progesterone resistance because basically their estrogen is defective, or the first phase, the follicular phase, is not what it should be. And here what happens is that it is the receptors. It is the estrogen receptors, the alpha and beta. And therefore, again, the progesterone receptors are not proper because it actually upregulates the progesterone receptors. Hence, in conditions like endometriosis, in conditions like fibroids, in conditions like pelvic inflammation. So actually it is nearly the WHO type 2 who are showing an ovulatory dysfunction. They are also having this kind of a problem with their progesterone. And hence, because of the receptors not being proper, and therefore the uptake of progesterone is not there. Hence, they are showing a resistance, and we do have to supplement these patients with more of it.
Yeah. So then what is the maximum dose you have gone to on a daily basis?
Sometimes you have to give three. You have to give three forms of progesterone. You're giving diprogesterone or natural micronized. I won't give natural micronized progesterone orally because I'm using it vaginally as well in the form of a gel or a pessary. And then you add on the parenteral. So sometimes we are blamed for so much of progesterone because the obstetricians then tell us that it is affecting the liver, and you people have caused that kind of a problem. They find more of cholestasis over there. But I do not know how much, because again, there aren't too many studies telling us that every patient is going to have this kind of a thing when you are increasing the level of progesterone. It depends from patient, and what we are today talking about is personalized progesterone treatment.
Yes, absolutely. Absolutely. It's all about personalized care. We have to optimize, our treatments, because there is no definite answer to everything today. And therefore, it's question of also every patient behaving differently, and we need to do whatever we need to do to get her the, best form of pregnancy without harming her or without harming the fetus. So question again is that when we are giving progesterone, any adjuvants which you like to add along with the progesterone? And does it help? Again, a controversial topic.
There are two kinds of adjuvants that we generally use. One is basically to improve the blood flow, I would say. And again, this is very variable, country to country and maybe clinic to clinic, where some people are, convinced that there is a problem with the blood flow, like I am. I always get it done. I always see that there is enough blood flow into the uterus and endometrium, whereas others don't believe in it. But then if it is there, because when we are talking about this, we have to talk of the continuum of this pregnancy, and we find that blood flow problems do need to placental insufficiency later on in pregnancy. And hence, if it is corrected right at the beginning, the placenta which is going to form is going to be normal. Therefore, I generally supplement with aspirin and low molecular weight heparin in patients where I find a compromise. And then, of course, the major controversial issue is that of the immune system, whether that is also acting up. And that would actually be more important in patients where you're having a recurrent implantation failure, or where you're not being able to achieve a pregnancy with just progesterone in the second half of the cycle. In those cases, you really want to know what is actually happening and what you can do to help this patient. And probably we go overboard and start thinking of things which are not actually going to help. But yes, immune testing and immune supplementation by immunoglobulins or IVIG and intralipid is something which is becoming quite popular, and it is gaining importance. I think COVID has taught us a lot of immunology now, and we are really concentrating on what is happening inside the uterus as far as the paternal antigens and the paternal part of the embryo is going to be implanted or not.
And what is your favorite immunotherapy? Any of these adjuvants, like say HCG, agonist during the luteal phase, the PRP. There are so many things which are being used, for as adjuvants in the luteal phase. Of course, low molecular weight heparin, then people are using GCSF. I mean, there's a whole lot of stuff happening. Which is your favorite out of these?
So some of these that you have mentioned are to be used in the follicular phase before we transfer, like GCSF and all that, to improve endometrium. But then HCG is something that is popular now, and intrauterine HCG has also become popular. But again, that is to be used before the embryo transfer to improve the endometrial thickness and pattern. However, intramuscular HCG is used as a supplement in luteal phase also by lots of people, because basically it is known to improve the implantation factors over there and increase the receptivity of the endometrium. So therefore, people are using it. Again, I use it selectively in patients where they are repeatedly, showing a failure and not implanting, and you really do not know, and you think, chalo, let me give this also and see. But I really have no solid reason to tell you, that, okay, this is helping me or this is not helping me, because you really don't know at the end of it what really helps a patient or not. It depends from your patient to patient. But I do use it. I do use it.
You do use it. Any tests you do for it to know whether you really need it or not?
Not, no, I don't do any test. There isn't any. For the
Yeah, go ahead.
If I have to use any immune modulator, for instance, intralipid or something, or in IVIG, there I do like to do these NK cells in the blood. Although that again they say is controversial because it's not telling us the uterine level. But what I try to do is I try to simulate the cycle, and I look at the progesterone levels. If there is adequate progesterone, then I do the NK cells and see in the blood. And if they are normal, then I don't support it with any immune therapy. But if I find that despite there being enough progesterone, there is a very high level of NK cells, then I do supplement them. And I do supplement it with intralipid because that is the safest. That is the safe, doesn't give rise to any problems or side effects.
Absolutely. So I'm so happy to, having this discussion with you, Sonia, but we could go on for maybe an hour or two more. There's so much to be, but unfortunately we will have to, come to some conclusions which are already mentioned in our guidelines. And to summarize what we have discussed, I think there is no consensus today regarding the type and duration of the progesterone we are using for all our frozen cycles. Yes, it is known that the level should be anywhere between at least 9 to 10 nanograms per milliliter. And usually if it is above 20 or so, again, it would affect the pregnancy rate. So ideally, it should be between 10 to 20 is a good level to have when we are doing the transfer. And for luteal support, again, you have mentioned there are different options available, whether we use vaginal, whether we use injectable. And probably you also must be continuing it till 12 weeks of pregnancy.
Yes, I do.
That is cycle. And the reason being that there's no corpus luteum in a frozen cycle, especially if it's an artificial cycle.
Absolutely. Absolutely.
Yeah. And then, of course, today, this is what is there in the evidence and the guidelines. And what we have discussed is something similar, though we may have answers to some of the questions and some of them we don't have evidence. So, is there anything last you would like to end with?
Well, we have come a little far. I won't say far, but we have sort of broken the ice and we have started delving into this kind of a situation as well and looking at the luteal phase. I think in the years to come, we'll be more clear as to what is the optimum support which is required for an average normal person, or an, I wouldn't say a hyperstimulator or normostimulator, I would say somebody who had not formed too many embryos. In the poor responders, we are again at a fix. We do not know what is better for them, whether we should do a fresh one or a frozen one. And in the hyper responders, we are very clear that it has to be a frozen embryo transfer. And we will learn much more as we go ahead about these people. Yeah.
So thank you very much, Sonia, for being with us on this Aspire Ed Talk. It's been a pleasure talking to you, and thank you, listeners, for being there.
Thank you very much for giving me this opportunity. It's an honor for me to be a part of any of your programs, Duru. Thank you so much for this Ed Talk. Thank you. Thank you. Thank you, Aspire. Thank you, Aspire.